Hello, and thank you everyone for joining us. I hope this will be an interesting and informative discussion around some of the latest data in rheumatology. My name is Professor Peter Nash from Griffith University in beautiful downtown Brisbane. And today I'd like to welcome to the CSF podcast, Professor Charis Meng from the Division of Rheumatology, Hospital for Special Surgery and Department of Medicine, Weill Cornell Medical College, New York. Welcome, and thank you so much for giving up your time. I know how busy you are. Today, we're going to talk a little bit about her recently published paper in Journal of Rheumatology. Can patients with controlled RA taper methotrexate from targeted therapy and sustain remission? Systematic review and meta-analysis. So welcome, and just to set the scene a little, can you tell us about your background and your interests and where you're working at the moment and what you're working on?
Oh, certainly. My name is Charis Meng, and I am a clinical rheumatologist at the Hospital for Special Surgery and the Weill College of Medicine. And I've largely been in clinical practice. Over the past few years, I've been working with Vivian Bykirk here at our Inflammatory Arthritis Center here at HSS. And we've been working on her catch cohort in early RA. We have a center here at HSS as well as her catch cohort in Canada. But we started with this systematic review patients with rheumatoid arthritis tapering methotrexate from combination with targeted therapy.
Tell us a bit about the scene in the US for those unfamiliar. Is methotrexate 100% used as the first biologic of choice, or can you go straight to, not a biologic, sorry, first conventional synthetic DMARD of choice, or can people go straight to a biologic if they wish, depending on their insurance? How widely is MTX used?
I think methotrexate is still often used as a first-line therapy unless there's a reason not to do it. In general, it is still our first-line therapy. We obviously have situations where either because of hepatic issues or we have a young female patient who wishes to try to conceive, where we will go straight to a TNF agent. But for the most part, it remains our first line.
So you do have the option to go straight to a biologic if you wish, if you can argue a good case. And does anyone use subcutaneous methotrexate? It's only recently been introduced to our country.
Yes, I think this is a good thing to point out. I think subcutaneous methotrexate could be used more often before transitioning to a biologic. It's something that we do discuss, but something that I think could be brought up more often, especially with our trainees.
So tell us a little bit about your study. In particular, what were the aims of the study?
Well, the reason we decided to pursue this was because a lot of our patients, as we were just alluding to with rheumatoid arthritis, often struggle with the side effects of methotrexate, and adherence to methotrexate remains highly variable. And for many of our patients, I think this is often something patients initiate. Tapering RA therapies remains a desirable goal for them, especially when their disease is under control. And our ACR guidelines, they conditionally recommend the tapering of methotrexate before tapering biologic DMARDs, but acknowledge that there's an absence of direct evidence. And when you look at the prior reviews on tapering methotrexate when combined with biologic agents, they focus on tapering from combination with TNF inhibitors only. So we wanted to do an updated review addressing methotrexate tapering when combined with other targeted therapies, including IL-6 inhibitors and JAK inhibitors. And we wanted to do it in a systematic manner. So our objective was to determine if patients with controlled disease, whether it be remission or low disease activity, while taking methotrexate with a targeted therapy, whether it's a biologic or a JAK inhibitor, can taper methotrexate and still sustain remission.
So excellent. So in our country, roughly 30% of patients are monotherapy for a variety of reasons. What's the kind of monotherapy background in the US?
It's about 30%, give or take, depending on which
Fairly
study
consistent,
you look at.
fairly consistent around the world. And because of that, a lot of our IL-6 and JAK inhibitor patients are on monotherapy. Is it similar in the US?
I think it is similar because of the data I think that we're all seeing. That the JAK inhibitors and IL-6 inhibitors might do better as monotherapy. So that's what we think of if we have somebody who cannot take methotrexate.
So tell us about your methods. How did you do the study?
We did a systematic literature search, and we were looking specifically for prospective comparative studies of adult patients with controlled disease that were tapering methotrexate from combination with biologics or JAK inhibitors, and they had to have reported remission outcomes. So this was not just RCTs, but we allowed observational comparative studies as well. And we found 10 articles that met our inclusion criteria.
I love the way you start with 4,400 and you wind up with 10. What was the exclusion for most of those studies?
Yeah, it actually reporting remission outcomes was a tough one. They might have looked at something else like disease activity, but that was a main limiting factor.
Does that mean that of the 10, if one is big patient numbers, it swamps the results for the others?
We actually didn't find a huge difference with that. Our heterogeneity was zero, actually, despite the fact that we were not looking at a specific therapy. But we didn't find I think the oral shift study was one of the bigger ones, but we found actually pretty consistent results across the board. So
you looked at early disease, late disease, you looked at gradual taper and rapid taper, you looked at follow-up up to 18 months and one study 3 years. Tell us a little bit about your results, please.
Sure. So as you said, about 5 of the studies tapered methotrexate from combination with TNF inhibitors. So it was still, a big number, but we did have 3 that tapered from tocilizumab, and 9 studies were RCTs, and 1 was a long-term extension study. And what we found, our main analysis was the meta-analysis that pulled the results from 2,000 RE participants from the 10 studies, that patients could maintain remission with an overall relative risk of losing remission of 0.9, meaning they would have a 10% reduction in the ability to sustain remission. And we didn't find any heterogeneity. We also calculated an overall pooled risk difference of minus 0.05, where if you use this pooled estimate, if one were to taper methotrexate from targeted therapy in 20 patients, 10% or 2 patients would not be able to sustain remission.
And was there a difference between gradually tapering and suddenly stopping, as you'd expect?
We couldn't do a direct comparison because only 2 out of the 10 studies gradually tapered, and one of the gradual tapering was pretty quick. It was over 4 weeks, but we didn't see a difference in flare rates when you looked at those 2 studies. But I think we just don't have enough. And that's an important point, that 8 out of the 10 studies just stopped methotrexate. And in clinical practice, we may opt to gradually reduce to find the optimal dose for our individual patient.
What about late versus early disease and the ability to maintain remission?
Yeah, we wish we could, but there were only 3 studies of early RA. And of course, those were the methotrexate naive patients, and the rest were, the 7 studies were of established RA that had a methotrexate inadequate response. And we couldn't make a direct comparison.
Okay. And was it important to have a placebo control in these studies, or was active disease and active comparator an issue at all with any of the studies that you looked at?
Most of them were placebo controlled. It was either 7 or 9 of the studies were placebo controlled.
Okay. And tell us a little bit about whether there was a difference between stopping, say, etanercept versus the monoclonals, and stopping with the IL-6 and the JAKs versus the others.
Yeah, we didn't actually, because there were so few of each studies, we couldn't compare. Out of the 5 studies that tapered from TNF inhibitors, 3 were etanercept, and then 1 was certolizumab, and 1 adalimumab. But we really just didn't have enough of each group to make a direct comparison. This was more of a pooled estimate from a range of targeted therapies, but I think those studies do need to be done to answer your question.
Okay. And when we did the etanercept withdrawal study published in the Lancet, Joe Smolin, first author, the duration you were in remission before you tried to taper drugs, in that instance of the etanercept that was tapered, seemed to have an impact on success. Did you find that as an option?
We specifically looked at whether they had a run-in period, and the SEAM trial and the oral shift study were the only 2 studies out of the 10 that had a 24-week run-in period. So again, too small to make a direct comparison. But again, I think that's another limitation of the included studies. That, the rest of the studies, it was just a remission or low disease activity requirement before tapering at one point in time. And most of the studies only required low disease activity. They did not look at remission for their criteria. And our main outcome was the proportion of patients who could sustain remission. So we did do another analysis looking at the risk of losing low disease activity as opposed to remission, and we found similar results.
Similar results. You looked at X-ray damage, any impact on damage?
3 studies looked at radiographic outcomes and didn't see a major difference, but here again, it points out a challenge with a lot of tapering studies, which is length of follow-up. The longest follow-up was 18 months. So I think we need more longer-term data for radiographic outcomes.
And you looked at function as well?
Yes, and there were some studies that found a slight increase in HAC and the physical function score in the SF-36. There was one study by Pope that found trends for worsening with patient global tender joint count, found a difference with more morning stiffness, but some of these didn't reach significance.
Okay.
But it raises the question.
Go on.
It just raises the question that if they'd been followed out longer, could some of those functional outcomes have reached significance?
Was there any safety signal either way?
No overall pattern. There were a few studies that showed more adverse events in the group treated with methotrexate. There was one study that had more adverse effects in the combination group, but overall, no strong signal.
And I noticed that when you looked at TOFA, maybe the numbers were small, that when you tapered methotrexate from TOFA, there was a very low remission maintenance. Is that just a quirk of the numbers?
Well, they also looked at persistent remission. I think that was the only study that looked at persistent or sustained remission over many weeks. So then the numbers go into the single digits, which is consistent with other literature, I think, of just sustained remission over time in RA is uncommon, even when no changes to therapy is being made.
So it's more a disease than a drug effect. And finally, recapture. Can you recapture patients who flare once you've tapered if they lose remission?
The SEAM study did look at recapture, and they found that 75% of patients that tapered their methotrexate were able to regain remission. The long-term extension study found that those who restarted methotrexate later, more than 4 weeks after stopping, had worse scores, but didn't give a recapture rate. And I think that's an important point too, that we have to counsel our patients before tapering methotrexate or any therapy, that they may not be able to regain what they had at the beginning.
But if you're going to flare, restart early rather than late.
That's right. That's right. That's a key message.
Okay. And predictors on who will flare, you've got seropositivity, high baseline disease activity. Anything else?
I think we only had 3 studies that looked at predictors, but they were consistent with what we've seen in the literature. Higher erosion scores, worse functional status, all seem to be pretty consistent, but there doesn't seem to be one biomarker we can consistently go to yet.
And the other thing, I was interested that early disease, 16% flared if you tapered, and late disease, 8% flared.
I know.
And I would have guessed it'd be the opposite.
Yeah, no, you wouldn't expect that, but I think it would be great to see more studies of early disease.
So can you give some advice on future study design? What should people do in the future if they're looking at tapering studies to answer some of these questions?
I think it would be great if we had more studies on early disease, and if we had more of a run-in period, to address sustained remission prior to tapering. And it would be great to see a more pragmatic approach to tapering, which is to gradually reduce, to find the right dose for the patient. And obviously longer term follow-up to look at the radiographic and functional outcomes. And obviously these studies would be more expensive to do, more difficult to do. And until we get data like that, we did make it a point in our paper to say that we advocate for the continued use of methotrexate when patients are doing well in combination with their targeted therapy. Because we think that it has value and additive therapeutic benefit over time until those longer term studies show otherwise. This study was really meant to help inform patients and their practitioners that if there's an issue with fatigue or GI upset or concern for the liver, or for that female patient that needs to stop it because she's going to be trying to conceive, to inform those discussions about whether it's a good idea or not.
So we tend to use ultrasound to help us decide who can taper, make sure there's no subclinical synovitis, normal acute phase reactants, nothing to find, and then they might be more successful. No information on imaging to help decide successful taper.
I think some of those studies have, yes, there have been some studies using ultrasound to help taper. It just, it wasn't with methotrexate
in your
in this context, yes.
Excellent. So any take-home messages for our audience? It sounds like if you taper, you've got a 10% risk of flare, and then the patient has to decide, and 75% chance of catching it back. So the patient has to decide if that's for them or not. But any take-home messages for the clinician?
Yes, that now we have some data that if that for our patients who are not tolerating methotrexate well, who want to taper it for some other reason, that the data says that they may do so, but they risk about a 10% ability to sustain remission. But again, this only goes up to 18 months, and that is definitely something to bring up with the patient, that there's a possibility of disease worsening, and they need careful follow-up and prompt retreatment to recapture their remission.
Excellent. And Burmeister showed you if you cut the MTX to 10 milligrams a week, you can maintain its benefit. Did you notice anything or any recommendations on dose rather than cessation completely if you don't want to risk that 10%?
Yeah, our data didn't come up with a consistent dose, but from prior data that makes sense. It makes sense with the state of the data to reduce the dose rather than to stop it completely, which many of these studies did. And one could look at the data and say, if the risk of losing remission is 10%, then we could reduce that risk by lowering the dose gradually rather than stopping it completely.
Excellent. So thank you again for your time. It's greatly appreciated. We know how busy you are. If you'd like to know more about this paper and others uploaded to the CSF website this month, you can get detailed slide sets are available in the publications section at cytokinesignaling.com. Please subscribe to this podcast on iTunes, Spotify, other podcast media you use, and give us some feedback. Let us know what you think. Thank you so much. Greatly appreciated.
Thank you, Peter.